Thank you. Good morning, everyone. My name is Nathan Tate. I am one of the project managers for the ICD-10 program team. And what we want to do here today is provide a series of specialty-specific presentations that are more focused on your particular area of interest. Today's session is focused on cardiovascular and thoracic surgery. We do have other presentations that focus on different medical and surgical specialties, and those are actually posted on the ICD-10 website. So I'll be giving out the link to that site via WebEx chat, and that is available anytime your schedule permits, just really on demand with those presentations. So I will go ahead and turn it over to Alan Brady, our presenter, to introduce himself and get us started this morning. Alan?
Again, this is Alan Brady. Thank you, Nathan. And a little bit of background about myself. I was a registered nurse in ICU, open heart recovery, mostly at some staff unit. I also was a case manager, a coding director, auditor, and contractor for a number of years. And for the last 5 years, I've been doing CI, where I spent about the last 2 years with a focus on ICD-10, which brings us to today's training. As been said, we have a number of these sessions, some overlap in the core content, and then a slight little variation at the end of each one for these different types of topics. This session will be talking about vascular thoracic type procedures and issues. So without any further delay, we'll get started here. We'll be talking about complications, acute blood loss anemia, debridement, respiratory failure, renal issues, encephalopathy, ICD-10 issues, and some specific CVTS respiratory complications procedures, as well as shock. So, why is this important? Well, of course, we're doing this in preparation for ICD-10, and we're used to probably having a CDI program where we do our queries. In the past, we've looked at complicating comorbidities and major complicating comorbidities, but this is becoming more and more important because we have an increase, sort of an overload of quality initiatives that are all risk-adjusted. Everything from your provider, your accountable care organizations, and your heart condition categories to your value-based purchasing, to specialty initiatives such as the NQF, PQRS, with patient safety indicators, mortality and morbidity, and this is all readily available now for the public or in the process of being made so. And just about anything that a CDI would query you on for an inpatient DRG would also overlap as a diagnosis that would be a risk-adjusted severity diagnosis that would help you in a number of ways to justify the outcomes, the cost, the resources, and the length of stay and the increased risk for morbidity and mortality that you would see for that population. So jumping right into surgical documentation considerations, one of the things that we need for any surgery being done is the reason why the procedure is being performed, obviously, a description of the actual procedure performed, as well as other supporting procedures and services during the same operative episode. We need to know the specific anatomical terms and the specific sequence of events that occurred in order to properly determine that root operation, the approach, the intent, and the anatomical use that we're going to have to put in. And I'll show you a slide that shows all of those characters later in the presentation. We also need the findings that you may come across, the outcome of the procedure, and any additional conditions that develop during the procedure. So let's talk complications very briefly. Everything that has the word complex or even complicated in the title should be considered a surgical misadventure. Some do and some don't, but very oftentimes it's an expected outcome and it shouldn't have that direct cause and effect linkage to the procedure. And a good example of that is acute blood loss anemia, which we'll talk about in a few slides as well. What we're really looking at is making sure that we report all conditions that increase the resources. That could be extra labs, blood work, transfusions, length of stay, or additional days in a higher level of care, such as ICU or step-down ICU, and any additional procedures that are justified by that or treatments. ICD-9 and ICD-10 make distinctions between complications related to the surgery and post-operative conditions, and we need to be very careful about how we word that, and I'll talk more about that in a few slides. So We're teaching this now is a lot different than how we used to. It used to be that we looked for any nick, any laceration, any additional suture, any little thing we could, and we'd report it. And I think that powered a relationship a lot between surgeons and CDI. It also is not good practice when it comes to our quality initiatives and reporting things that may be part of the standards of care, or maybe they were foreseen circumstances, maybe it's routine. We shouldn't be reporting those as additional complications. So the way we teach that now is with these criteria. First and foremost, does a cause and effect relationship exist? There's no cause and effect relationship between that procedure or the device and the outcome. It's not a complication. It's just going to be a diagnosis of whatever that issue that is, standalone without being related as a due-to type of scenario. If it's unknown whether there's a cause and effect relationship, the physician may get a query. And if yes, we're going to go to the next session. The next session was, yes, we know it's a cause and effect relationship. Was it a foreseen circumstance? A foreseen circumstance is almost never considered to be a complication. An example of that I use is a patient who has a large tumor that has to be debulked, and once they get in and visualize it, they see there's a vascular bed tied up in it. Then there's going to be extensive blood loss, and they're probably going to have to call in a vascular surgeon. That's additional resources. Patient's probably going to have a longer stay. They may have to get a transfusion, but it's not an unforeseen circumstance. You got in there and you saw what needed to be done. It just turned into a more complex procedure. So we wouldn't use the threshold, any of the normal benchmarks, to try and make this a complication, because it was known what we're looking for is a situation where the surgeon is as surprised by the turn of events as everybody else. That type of an unforeseen circumstance with a direct cause and effect relationship may be a complication that we have to report. Patient, and if it falls outside of the standards of care. So the next bullet point is the standards of care. That particular outcome or occurrence is something that can be reasonably expected to occur on a regular basis, and if it does, it's not a complication. It's just part of the standard care for that type of procedure. So let's say we met all those criteria and we get down to the bottom. Did there any harm to the patient? If we didn't have to do any additional treatment, any additional days of stay, any additional lab work, nothing really occurred, it's more of an incidental finding and not really reportable as a complication. Now, if we met all of those criteria, then we absolutely should report it as a complication of the procedure. But I think what we'd find if we really looked at it in terms of these criteria is that it's a reduced number of applications being reported than what we initially thought that they might be, just by going by certain buzzwords in a chart the way we used to do it. Some examples are reporting of foreign bodies left in the OR. It used to be that once you closed the incision, that was automatically considered a foreign body. Now that threshold has been moved out. It does become a reportable incident until they leave the OR suite. So if they go out to PACU and then you find the sponge count is off, then you have to take them back into the OR suite, reportable as a foreign body left in during the procedure. A couple other examples, a pneumothorax, if you cross into the diaphragm or have a chest procedure, we shouldn't be calling them post-operative or post-pneumotomy or post-VATS complications. We should, because it's expected. A 5 to 10% pneumo status post-pulling of a chest tube should not be reported as a post-operative pneumothorax. If it's 15 or 20%, maybe, because then we got to do additional chest X-rays, additional meds, pulmonary toilet, additional days. They may start running a fever, something like that. Then it's reportable. But be careful about just writing, post-op pneumo and then having the coder just pick it up when it's such a small pneumo and it's a normal occurrence in that instance. We can report a pneumo without saying it's a post-operative pneumo or without giving that cause and effect relationship, and then it's just a standalone diagnosis of pneumo, but you don't get dinged with that post-operative complication code that gives you that cause and effect relationship. We do something similar with ileus. Ileus may not always be warranted as being due to the procedure, but they may still get one 3 or 4 days later from narcotic usage or maybe from pre-existing lesions that have nothing to do with the surgery today. We can still report the diagnosis, but we wouldn't necessarily call it a post-op ileus in that example. Here is expected blood pooling into a joint, such as a fracture patient, or you could have a lot of expected blood loss with a cardiac patient as well. That's expected. You can call it expected acute blood loss anemia. There's no surgical misadventure indicated there. If you wrote intraoperative hemorrhage or postoperative hemorrhage, there would be a surgical misadventure type of code added. But for standard acute blood loss anemia, there's not one. So there's absolutely no reason not to report it in the case, especially if it requires treatment. Some examples from the urinary chapter, just to show you how chapter-specific this can be. It used to be you had an intraoperative hemorrhage or hematoma code, and that was it. It was one code for all. Now it's body system. In this example, it's intraoperative or hemorrhage or hematoma at the genitourinary system. You would have exactly the same for cardiac, vascular, respiratory, so on and so forth. So some of the code expansion there just comes from having all of the different carve-outs for the same diagnosis as opposed to having the diagnosis be a global term that we did at ICD-9. So that's important to note. Puncture or laceration, that type of a thing would be a surgical misadventure. We probably shouldn't report it again if no harm came to the patient, or it was a routine finding, or we saw it going in and we knew we were going to have to do it. It's an accidental, right? Sure, required a repair, but it wasn't accidental. So we just need to be careful and clean our language up a little bit and realize what buzzwords the coders are cueing into on some of these things. Complications, you've got complication of vascular device, peritoneal dialysis even. The physician needs to link that. You can't have an infected AV shunt in one part of the chart, I should say an AV shunt being documented in one part of the chart, and then an infection of the arm in a different part of the chart. The code in the CDI is going to be looking to see if that cause and effect relationship is related, if it's due to the device, and if it's unclear, they may query you. If we don't know, then use your best judgment, whatever you think reflects the clinical truth the most. If it really is due to the device, then we have no choice but to document it. Remember, we will get dinged on those kinds of things, such as an indwelling catheter causing a UTI on our patient safety indicators and our value-based purchasing, our quality form stuff. It doesn't ding us if they had it present on admission, but we're only looking for conditions that occurred during the hospital stay. Say to report, again, if you don't know, you don't know, and not everybody who gets a UTI has a folate, so sometimes you don't know, and that's okay. But if it appears to be related to it, then you can document it. You're really safe to do it if it's POA of yes. If it occurs during the hospital, make sure that you really think that's valid before you write it down. We sort of are that if we get a little increased severity on that particular stay on that one chart, but then it kind of comes back and gets us on the backside with all of our quality initiatives and our value-based purchasing. So, yeah, we'll have some, and we need to document it when we have it, but you should use judicious review whenever you do those assignments. So here we have acute blood loss anemia. Again, does not imply a medical adventure, may be an expected occurrence. Just, again, looking for something that increases that resource. Another example of a condition that doesn't imply any surgical misadventure that will occur post-op would be the post-laminectomy syndrome. The surgery was perfectly well, but in the post-op period, 6 months later, they have the syndrome. And so just don't say that it is due to the procedure or as a result of. It's simply a standalone diagnosis. Blood loss anemia can come up in a lot of ways. You'll see it a lot in your cardiovascular thoracic. And so can't use did they get a transfusion or not as our benchmark for whether we should report this, because they all get transfusions. And there's always a significant blood loss. It's really only for a CABG or some kind of a thoracic vascular surgery would only use it if they get more blood than what the standard expectations have been, or if they have into complications from being anemic, such as hypotension, rapid heart rate, rapid respiratory rate, that may be reportable in these conditions because it's an outlier from the standard of care. If it increased their length of stay, we had to go back and give them an additional set of units, then it may be reportable. So keep in mind, a high amount of blood loss and some transfusions are innate in this category. We generally look for a drop of 2 to 3 points before we do the query, but we're not going to do it if they drop from 15 to 12. We're looking for a drop of 2 to 3 points. They go below 10, and also is not easily explained by IV hydration and hemodilutional effects. So these is the way we're teaching these topics. We're teaching CDI now. Risk of surgery can be blood clot. So DVT, again, if we're present on admission, we will get dinged for it, and it happens, right? It happens sometimes. But the talking point is that we need to make sure, if it was present on admission, that we document that it was a pre-existing condition so that we can get that written correctly, and it comes off of our quality focus. We still capture it as a pre-existing condition, so it actually still helps us on our risk adjustment. So that's a good way to sort of get around all of that. Infections of surgical wound, heart attacks, hemorrhage and hematoma, wound dehiscence, acute respiratory failure we'll talk about in some more detail in a few minutes, accidental cut and lacerations, foreign bodies. All of these things we would want to report, make sure that we get the POA correct, and we need to watch how we word that cause and effect, whether it was due to or it was just a standalone thing that happened. Some of these things are unavoidable. For DVT, maybe a post-op DVT, and it's going to go to vascular complications with your DVT, but it could be that they were high risk for a DVT anyway, and we can't say if it was directly related to the surgery, and then I wouldn't call it a post-op DVT. I would just call it day 4, patient now has a new DVT. It's a word game, but it's something you do have to think about in a lot of detail. This patient had a estimated blood loss of 1 liter and was transfused with 2 units and had a significant hemoglobin. The terms that didn't work were blood loss, blood loss anemia, transfused, and expected blood loss. But when we queried for acute blood loss anemia, we got over 2 days in our length of stay and almost a full point risk adjustment. The higher this risk adjustment model is, the better. The higher the number is, it means that the higher the cost is expected to be, the higher the length of stay is expected to be, and the higher risk of reasons and or morbidity and mortality coming from that. So that is where it really helps you in terms of your final scoring, is all of that risk adjustment there. Debridement in the surgical population needs to be written as an external debridement, surgical removal, cutting away of devitalized tissue, necrosis or slough. The terms that we're really looking for, what we want to see, was whether it was an excisional debridement, whether they used scissors, where the location of the wound, what was the wound, was it fresh, bleeding, viable tissue, the depth, as well as what was taken out. So if you say I debrided down to the bone, we need to know if that means it was down to and including the bone, for example, external infection, or down to but not including the bone, and just be subcutaneous tissue in that example. We will only code to the deepest layer, and it's just important to know what was taken out. So here we have our query for that, and then rather than asking was a debridement done, we'll simply ask for the mechanics of the procedure. What was the debridement, what was the depth, type of tissue, and location. And from there we'll make a determination, or your coders will make a determination about whether or not it was a surgical debridement or not. The terms that didn't work here were debrided, sharp debridement, or wound debridement. But we saw, hypothetically, that there was a very clear wound, and a scalpel was used, an excision was made, and it went down to healthy tissue. So we did this query. And the physician agreed to excisional debridement, and you can see that moved us to an entirely different DRG. Almost 2 additional days to take care of our patients, and not quite double the risk adjustment, but it's significant. This is a resource-based model, and what CMS is saying here is that if you've got to start doing debridements, then you're expected to have higher costs and added days to your length of stay, and added expectancy that there might be readmission. So again, that's why all of this is important. So to respiratory. Respiratory failure is something that we still struggle with. It came up in your top 21 diagnoses, as well as all of these topics that we're discussing today for opportunities even within your surgical population. These are the 4 defining criteria that we use. We recognize that you can't always get blood gases, and we also recognize that pulse oximetry can have shortcomings, but it's the best we have. So if a CDI sees a low pulse ox or oxygen 4 liters or greater, they're going to start looking, and I really like the PF ratio as for this, because it takes into account both the oxygen therapy and doesn't necessarily require you to have the ABG. And so from that, you can get a good indicator of how much of the available O2 they're able to absorb. We don't even know their baseline. Ventilation is not necessarily a requirement. I would say high flow oxygen BiPAP, yes. If there's stress, yes. Be careful of using the term respiratory insufficiency or respiratory distress. The way we want to look at this is acute respiratory failure is our severely ill patient. Acute respiratory insufficiency or acute respiratory distress is a moderately ill patient. That's how it's going to be categorized. If you just write respiratory insufficiency or distress without the word acute, it carries no severity. It carries a simple sign and symptom, and there's going to be no more risk adjustment available to your record than would have been that they would have already had just from their primary diagnosis. So that's the number 1 bullet point there. We just covered it. Some additional things that we need to know if it's acute or chronic or both. And in ICD-10, we can show if it's hypercapnic or hypoxic or both. We didn't know whether or not it was present on admission. Again, we want to know if it was a pre-existing respiratory failure, because that may end up becoming the principal diagnosis. And it also helps us with the quality to show that we had a lower incidence of people getting respiratory failure while they were in the house. Some codes. In ICD-9, we had pulmonary insufficiency following surgery and trauma. In ICD-10, we got acute pulmonary insufficiency following surgery, or acute pulmonary insufficiency following non-thoracic surgery. And we have this, chronic pulmonary insufficiency following surgery. And this would be for someone who can't come off the vent or continues to have severe respiratory problems, maybe needing high-flow oxygen BiPAP for several weeks, or at least a couple of weeks post-op. And also be for someone who was transferring in from another facility, coming in and continuing to have a lot of respiratory problems that had turned into a long-term scenario, but started after they had a procedure done. So all of these carry a very high level of severity, and all of these are definitely acceptable to report. Acute respiratory distress, we typically reserve that for a patient with a intrapulmonary diagnosis, such as shock lung, necrosis of the lung, hardening of the lungs, barotrauma from ventilation, those types of things. If it's just poor gas exchange from some other chronic respiratory issue or fluid balance problem, then we will probably recommend using just a regular respiratory failure or acute pulmonary insufficiency following surgery, for example. Instead of using the terms insufficiency when you're trying to convey the highest level of severity, best if you just get in the habit of saying failure for that. And the same thing for acute and chronic. If you're trying to convey the highest level of severity, you generally will want acute. And if you're trying to convey that moderate level of severity, you generally want chronic. Here's a sample query for a respiratory failure. Patients O2 dependent baseline, but they had a very low PF ratio. They were tachypnic, speaking in one-word sentences, probably in distress. Low sat even on 6 liters, put on BiPAP, probably heading to a vent. And they had previously stable COPD, but now the HP notes acute respiratory failure continues to decompensate. That's all in the chart. Respiratory was never followed up on anywhere in the record because they improved rapidly, and we didn't get it. We didn't get that level of severity or any of that risk adjustment because it was only written in the H&P. It would be best if we would come back and write like respiratory failure in the ED or on initial presentation and now resolved, so that we'll know that it wasn't ruled out and that it was a verified and confirmed diagnosis. It's very hard on us in those cases, so are the commercial insurances. If it's not confirmed, feel free to write, you could write something in there showing the history of the progression of the record. It could have been another physician, under Dr. Smith, this was reported respiratory failure, now resolved, and now here's my diagnoses and my course of care. It's different from your E&M documentation because you can only really comment about what you do in your E&M world, but in the hospital, we're required to report all conditions from the moment they set foot through the door all the way in through discharge, not just what conditions physician A or physician B sees and treats. So I have a little bit of a mismatch there in our definitions. We got this acute respiratory failure, and you can see it gave us 2 full extra days and more than double the risk adjustment. So that is definitely a win if they met that criteria. This is going to definitely explain the longer length of stay and the higher cost of care. So ICD-10, I mentioned the hypoxic and hypercapnic already. The defaults are changing slightly. If you just wrote acute respiratory failure, that would default to acute respiratory failure in ICD-9. In ICD-10, it defaults to unspecified respiratory failure, and that's okay because it still conveys the highest level of severity. And again, are your postoperative and thoracic respiratory failure codes. Here's examples of some pneumonia. That's quite frequently when you go through this respiratory, thoracic surgery, trauma, that you're going to end up with pneumonia. And you can see some of the specificity. We don't always have cultures, but if you do have cultures, please document that relationship. If we just see the culture in one part of the chart and pneumonia in another part of the chart, they will not be linked. It will go to unspecified pneumonia. You could write culture-positive Pseudomonas pneumonia treating with, or even write suspected gram-negative pneumonia, therefore I'm going to treat with the antibiotics. And it's okay. The suspected is okay. It doesn't mean, as in the beginning of the chart in the H&P, suspected is kind of a differential, but at the end of the chart, last day of progress notes, this summary, suspected is valid, is confirmed because the cost of care would be the same for suspected or confirmed at the end of the stay like that. And then I also have just a few more of these. You can see what pneumatitis due to inhalation of other solids and liquids, that'd be our aspiration pneumonia, for example. And these additional ones that we wouldn't use very much. I also have some of the influenza combination codes on here. You can see at the top influenza due to the A virus with pneumonia or respiratory manifestations, and so on and so forth. Sure, we'll be here before we know it, and we'll be looking at these cases, and ICD-10 will be in play at that point. Let's jump into renal failure. Another big topic with a lot of available specificity that we often miss. It's important to distinguish intrarenal pathology from pre-renal pathology. We do sometimes get back where we say, well, ATN is a type of AKI, and I already told you AKI, so why are you bothering me? That's all true, of course, but they don't convey the same levels of severity, risk adjustment, and they don't have the same expectations for cost of care and length of stay and readmissions, obviously. So we do need to differentiate between those diagnoses. If you write acute renal insufficiency, that's not going to convey anything in terms of severity for us to report. It needs to say acute kidney injury or acute renal failure. That gives us a moderately ill patient, and we'll take that, and that should be what's reported for all pre-renal AKI or ARF. According to the IGO, 30% of all renal failure in-house is actually acute tubular necrosis. We don't see it reported at that rate. We see it maybe 5-10% at the most. So what's happening here, some are being missed. There's opportunity for improvement. I don't think we'll ever get to the 30%, and that's okay. Research done in academia can pull forth diagnoses that we can't necessarily do in the real world, but I still think that there's room for improvement. And even though a lot of your renal lesions, such as glomerulonephritis, glomerular sclerosis, interstitial nephritis, they have to have a renal biopsy for those. Acute necrosis can be diagnosed clinically by looking at whether or not they what the precipitating event was and whether or not they respond to treatment. It's simple. If there's cells in the urine, a urine electrolyte would help a lot. So we know that we can diagnose those ATNs, and we should look at them. So look at the difference. Renal failure is a moderately ill patient. Tubular necrosis is a severely ill patient. Acute insufficiency or azotemia, no additional severity. Chronic patients, CKD stages 4 and 5 are moderately ill. Renal disease is considered severely ill. All right, encephalopathy, another very common diagnosis that we deal with in the surgical population. Encephalopathy, we're looking at metabolic specifically because that's usually what we're talking about. It's always due to underlying cause, which can be hemorrhage, METs, tumors, ischemia, poisonings, and systemic infections such as sepsis. It's a common finding in 12 to 33% of patients suffering from multiple organ failure, but again, we don't get it reported at that frequency, which means we're probably underreporting it some. We don't recommend going crazy with it and documenting encephalopathy for someone in a post-ictal period or someone with a hypoglycemic, someone with a very transient condition or altered mental status. We would not report encephalopathy for those, but we report it when it is an acute confusional state due to an identifiable underlying metabolic dysfunction. So in those cases, we should report it. And here's sort of a comparison, unspecified metabolic. This is still using the ICD-9 codes, but the ICD-10s are pretty much the same, except hepatic. Hepatic encephalopathy can't be reported unless the patient is in a coma in ICD-10. So if you have a patient with an elevated ammonia level causing confusion, that would be metabolic encephalopathy in ICD-10. We're not trying to get around the rule there. It's just that it is not, there's no way to index it. It's not reportable as hepatic encephalopathy. It's only reportable as hepatic coma, with almost no patients, very few patients. So we'll have to switch that to metabolic encephalopathy due to hyperammonia levels, elevated ammonia levels. Encephalopathy should only be reserved for patients who have a chemical or drug overdose or some kind of poisoning. Coders will see that and they'll start looking for what the toxicity was. They are really going to consider the fact that it might be a naturally occurring metabolite that is just not being excreted. So, right, toxic metabolic, that can really confuse a coder. It's a naturally occurring substance that's poisoning the patient because they can't excrete it. We should probably just write that as metabolic encephalopathy and reserve toxic for poisonings. Then you have your moderately, and all of those, by the way, at the top are your severely ill patients. Half of your moderately ill patients, hypertensive, alcoholic, anoxic, and Wernicke's. Anoxic encephalopathy is the goal. It probably should be the highest level severity, except we do sometimes report it for patients mildly hypoxic, for distress and failure, and then turn around and it is transient and reversible. And in that case, this only being a moderate level severity instead of a severe level severity is probably justified if we would even use it in that way. Oftentimes we don't, but it's here, it's an option. We could use it that way to report the moderate level of severity. Same thing for very transient levels of confusion in a very hypertensive patient, hypertensive emergency, hypertensive urgency that accompanies an acute confusional state. Only talking about a moderate level of severity, and if it's linked to that, it's reportable here, and you can see shouldn't be any reason not to do it that way. Okay, when a record is documented as both delirium and encephalopathy, I would caution you because RAC and the commercial insurances will call it inconsistent documentation, and they'll take encephalopathy off. They may take both diagnoses off. So just it looks like we couldn't decide. We were going back and forth between the two. Delirium may not be appropriate. In ICD-9 and ICD-10, delirium is a psychiatric problem, not a medical problem. It falls in the coding index as either a sign and symptom, or it falls between either dementia and drug-induced dementia, which none of that is appropriate for a patient who has brain malfunction from an underlying metabolic problem. So if we want to report delirium, we should, for a patient with psychiatric problem issue. If a patient has drug-induced delirium or drug-induced encephalopathy, that can go either way. I only recommend drug-induced delirium for a patient who got psychoactive medications such as benzodiazepine, anesthetics, psychiatric medicines, narcotics, and then you had the confusion accompanying that. That would be drug-induced delirium. But if a patient had a medical drug such as high-dose diuretics, they double-dosed on it or something, and their sodium got way out of whack and they got confusion, I would consider that to be a metabolic encephalopathy secondary to a metabolic problem that just happened to be related to a medication. That's sort of how I break those up. We'll use delirium as a term for the observable manifestations of encephalopathy. I would recommend against that practice, again, because they will just say that was two completely different diagnoses, even though the literature uses the terms interchangeably. Oftentimes, the delirious patient is hyperactive and very combative, and an encephalopathic patient is depressed. So that's another good way of sort of distinguishing between the two as well. Helps a little bit with that. It's a very, very controversial subject. We have a new code in FO5 a new code in ICD-10 called FO5 that will help with a little bit of this. So you see the third one down, we have acute and subacute infective psychosis. We have been telling CDI not to query for encephalopathy when there is only a localized infection. For example, the 70-year-old grandmother that has a UTI, no other source. It's accompanied by an acute confusional state. Then call that encephalopathy. It's probably a good practice. If they were septic or they had a systemic condition or other electrolyte abnormalities, they were hypoxic, whatever, then it's probably metabolic encephalopathy, but not just from a UTI. So in ICD-10, we can call it FO5, subacute infective psychosis, and that's at moderate level severity. You're not reporting a severely severe level severity. I think that's very appropriate. You see that we also can assign this code for sundowning, which is great. We're going to do that in ICD-9. And we also have delirium superimposed on dementia, which can be worse. It can be very reportable here as FO5 in a patient who's demented and has sort of an exacerbation of their dementia. The delirium, I think we can report this as F5, but if the patient is a demented patient and has a medical illness, such as sepsis, or they're severely hypoxic or severely anemic or something like that, then we probably shouldn't call it delirium superimposed on dementia. That's not a psychiatric issue. It's an underlying medical problem. So then we should probably default back to the metabolic encephalopathy for those situations. Again, I already mentioned the point with the hepatic encephalopathy will not be a codable term. They must be in a full-on coma if they have that, and it's going to be a huge change. It's going to take some getting used to. Down to ICD-10 specifically, we're going to talk about procedures here in this section. And the background on this is that CDI typically only review for things like principal diagnosis, what was POA, what's PDX, and there are complicating comorbidity. Is it a patient safety indicator? Is it a 30-day readmission, a HAC, so on and so forth. We may look and see if debridement was documented correctly or if a cardiac cath was done that might have gotten missed because there was a cabbage and a few other things. But for the most part, they don't read op notes. It is said that this could be one of the largest growth opportunities for CDI and going forward is to have someone who is a surgical specialist who is just as much about ICD-10 PCS as a coder, but also functions in that nurse clinician capacity to work with the doctors to make sure that all the elements of the op notes are being documented so that records can be coded and not held up. An example here is cardiac adhesions. So 15 to 20% of open heart procedures have adhesions, 100% of reoperations, and it's a tedious slice of adhesions. It can take an hour or more, and incidental injuries are common. Should we report those incidental injuries? Probably not, but in some cases, if they're bad enough, we might have to. The reoperation for this is release. It's not lysis, it's not adhese, not adhesiolysis. The doctor has to know to go and look up the term release. That only gets them about halfway there because the physician might respond, well, the cardium wasn't physically constrained. Look at the definition. For a body part from an abnormal constraint by cutting or use of force. So there's another piece that we're missing. Now we've figured out the root operation. We've got a specific site. There is no code for release heart, not otherwise specified. You have to know if it was the right or left atrium, or the right or left ventricle, or the pericardium. So if this said heart, you're query on that. And unfortunately, there's no way around it. The bill can't be adjudicated without that query. So in that case, this is where cheat sheets and templates might come into play, sort of reminders. Work with your CDI, work with your coders to find out what those common required elements are. This is just an example. There's a lot more out there than just what's here. Terms ectomy, otomy, ostomy, ablation, and plasty are nowhere to be found in the entire 72,000 choices of ICD-10 PCS codes. What we need to know is what were the actions, the intent, sequence, and technique. The intent comes in sometimes trying to figure out if it was a therapeutic procedure or a diagnostic procedure. The technique's going to come in terms of that root operation, that approach, and that those body parts. The analytical terms. A lot of this falls on the shoulders of the coder to figure out. I think one function that the CDI may have to play as an advisor to the coder to him trying to figure out these op notes without having to query the physician if possible. But in some cases, it'll be unavoidable. So here are characters that we're going to have to deal with: section, body system, root operation, body part, approach, device, qualifier. Look, section, body system is not going to be a problem, but the root operation could be a problem, especially if it's not cleared out. It's not very clear in the op note what was done. The anatomical issues are definitely going to come up as questions. Sometimes the approach and device will come up. Qualifier only in terms of if it was diagnostic or therapeutic. These root operations. You see creation, for example, about halfway down is only to be used for gender reassignment in ICD-10. So you cannot technically create or use that term to code it. Create like an AV graft for a bypass. Which includes patches, stents, and plastic procedures. So the coder has to know to go and look up supplant or supplement in order to get that creation. So they're kind of tough. You can't remove a kidney in ICD-10 because that's supposed to be for devices only. You resect a kidney, which is total removal of an organ. If you excise the kidney, that wouldn't be right either if it was a total rectomy because excision is for a partial removal, whereas resection is for the entire organ. So what we're essentially doing here is we've created a new language. It's the same language, but it's a new language because the definitions are not used here in a way that we're typically used to using them in our popular nomenclature. And we're going to have to all learn this and get very comfortable with it in order to be able to function in the ICD-10 world. There's going to be a learning curve. Definitely. Page 2 has some additional ones. Some of them make a lot of sense and won't be an issue. For example, fusion makes a lot of sense. Joining together and mobilizing, I don't think we'll have any problems with that. But trying to figure out, for example, the difference between occlusion and restriction, I've seen many coders get tripped up on that. Occlusion is when you completely occlude a tubular body, such as a vein or artery, and a restriction is when you partially occlude it. And of course, dilation, we have lots of other things. And this is not even all 31 root operations here. So, and there could be questions here. Did you completely occlude the the lumen, or did you only partially restrict it? That changes the code. Continue with root operations. This is really getting into sort of body site, though. This patient had cabbage with a saphenous vein graft, and we're trying to figure out, to code it, was it the greater or lesser saphenous vein graft? We got an anatomical issue, and ICD-10, there's no unspecified. There's no not otherwise specified. So this is going to generate an automatic query to the surgeon. Was it the lesser or greater saphenous vein that was harvested for the vein graft? And again, this is that anatomical term. If it was, we're having used those same exact words, somebody with a good knowledge of anatomy going in and seeing exactly at what level the incision was made could figure it out. But I think in a lot of cases, this would just, the coder of the CDI might not be comfortable doing it, so that would be one of those catch terms that you'd have to get used to documenting to cut down on some of these queries. So excision versus resection, again, if you were talking about lobes of the liver or lung or a region of an intestine, that would be an excision. If you were talking about all of the, where you wouldn't do a total liver. If you're talking about all of a kidney, that would be a resection. Again, if you remove the entire, and so now some of these are broken down though by lobes, so you don't have to take out all of the lung, all 5 lobes. With the lung, if you remove one whole lobe, that actually is considered a resection because it is the entire section. And if you do part of a lobe, such as a wedge resection, that's an excision. So it does get a little tricky. People who know it quite well get confused and have to kind of sit down and reference this, including myself. Body part. What the closest match? Will coders feel comfortable extrapolating that? We just talked about that on the saphenous vein graft. And if they knew the exact level, they still might not be comfortable extrapolating that to the closest match without the term. Know the specific part of the bone, the specific depth of the procedure. I part and the anatomical terms could generate more queries than maybe any other component of PCS, at least at first. Approaches, something that we have to look at. So the example here, a simple tonsillectomy would actually be an internal approach because you can get to it without any instrumentation and without any additional visualization or anything like that. If you have a small incision, that's obviously percutaneous, and if there is an endoscope or some kind of instrumented visualization, that goes to percutaneous endoscopic or percutaneous with instrumentation. So the coders are going to have to know a lot to do procedures on here, and don't underestimate how challenging this is going to be. Case scenario here for this example, I've got code 3950, aplasty of other non-coronary vessel. That was one code in ICD-9, more than 170 codes in ICD-10, roughly speaking. And the difference is the exact anatomical location, whether it's a drug-eluting device, whether the approach, what was the exact approach, open, endoscopic, whether it was an angioscopic. So all of those things somehow got us from one code to almost 1,200 codes. That's a nightmare situation. Usually when you're reading these type of op notes, they're done so well that all of these pieces is already there in a lot of cases to pick out the exact code. That way, this is a good example because you're typically it's going to write exactly where you put things, exactly how you went in, and exactly what artery it was. But it is a work for the coders. Devices only applicable for devices that are intentionally left in, such as a graft, a stent, a pacemaker, generator. All of those would have to be separately reportable in that 7 characters as what device. And it's an infusion or some kind of administration. We know if it was autologous, synthetic, or non-autologous. We would report devices that are just adjunct procedures such as sutures, drains, cabbage. We don't go and report, hyperplasia, hypothermia, all of those adjunct procedures because they're included in the cabbage. They're standard care. The only thing we really want to know right now is if they had a bypass machine, and of course, what passed and from where to where and how many grafts it was. So that's not going to change too much in that respect, going from ICD-9 to ICD-10. Such as Whipple, Bill Roth, Nissan fundification, those terms are going away completely. To do a fundification, the coder would have to know that they're looking up for something like restriction of the upper stomach. So these terms are going away. That's going to be very difficult, especially if you were trying to do something like a Whipple procedure, and there's so much variation in that procedure. Again, procedures that are inherent aren't normally coded. I just gave that example with the cabbage and the hypoplasia and the hypothermia. Could, however, cause new coders to struggle. An experienced coder could probably tell which is which, but again, they may have to go and work with the nurse on that what's normally part of that standard of care. Reanastomosis, for example, would be included in the base description without being separately reportable in most cases. So we aren't going to start creating all the surgeons to use the exact root operations. It is our responsibility for the CDI and the coders to look at the technique and the steps, the sequence of events, and figure out what the operation should have been, and hopefully, if it's detailed enough, what that anatomical term. So as the surgeon, you really can just focus on getting the steps, the and what was done, why, and then if that's all there, we can pull this out, hopefully, in most cases. All right. Some complications, I know we talked about that earlier, but I've got some things here specific to this category. We've got trach complications. We've got pulmonary insufficiency due to anesthesia. We didn't see that in the other listing of respiratory issues that I had up before. We have intraoperative hemorrhage and hematoma of a respiratory system organ. That is going to be a procedure that would convey a medical misadventure. A code. If you had that, J95.6. Same thing for J95.7, accidental puncture or laceration. That's the type of diagnosis that will convey a medical misadventure, not anemia or respiratory failure. It's these. These are the ones that you have to make sure that everything is well documented and it was fully warranted. Procedural pneumothorax, again, I warned against using that if it is an expected small pneumo that's inherent to the type of procedure and part of the standard of care. Related acute lung injury, that's an interesting one. That would probably be a patient that we'd start looking for that ARDS diagnosis on as well. And then a mechanical complication of the ventilator here. Some areas that have been a problem for CI is your transbronchial lung biopsy performed by bronchoscope. That is considered a valid surgical procedure and will move you into a surgical DRG. But we need to know that it was a transbronchial lung biopsy. We can't just look and see whether tissue went to the path. It's very easy to look at these and think, well, it's just a bronch with a lavage, or if it's a bronch with a breaking, that's not a surgical procedure. That is just a simple bronchoscopy diagnostic type of thing. You have to have the specific term, transbronchial lung biopsy. Of course, it could be transbronchial needle lung biopsy in order to get to this code. So very clear, because sometimes just reading those op notes, it's not so easy as you would think to identify that. The stenoscopy, even though that's only really diagnostic and sound, actually does put you into that same surgical DRG because you're having to go all the way into the mediastinum, obviously. So does VATS, video-assisted thoracic surgery, will put you into that. And then there's a number of procedures. A tube orthocentesis by itself is not a valid OR procedure. And does not really count as any kind of CC or MCC opportunity. It doesn't really increase your severity. So, mechanical ventilation, we found whether they were on the vent for less than 24 hours, whether they were on the vent from 24 to 96 hours, or whether they were on the vent for greater than 96 hours. We used to could only do this two ways, and 96 hours was the cutoff point, and you were either over it or you were under it. Now we have three different ways of looking at this. We actually have to count ventilation hours because the patients who are on the vent greater than 24 hours will have some additional severity added, and the patients who are on the vent greater than 96 hours will have a lot of additional severity weight added to the chart. That's expected to be a much longer length of stay and much higher cost of care. Generally, we'll go to respiratory sheets and count this off. It would be if we had the dates and times in the chart somewhere that was easy to find. All right, so here's an example of the type of communication that is going in to coding clinic with ICD-10. This patient was a 72-year-old gentleman with a right anterior fourth rib coma who underwent a resection of a 9-centimeter section of the right fourth rib and reconstruction of the chest wall with a methylcrylate Marlex overlay. So they won't know how to code this. And the answer is on the next page. You have the excision of the right rib open approach for the removal of the rib, and you have to use supplement. Remember, this for patches and grafts. Supplement of the chest wall with a synthetic substitute open for the insertion of the Marlex and methyl methacrylate composite plate. So you've got two codes here, and even if the physician used the term resection, the has to know to go back and actually use excision, because resection would be all of a body part, in this instance only a portion of the rib reserve. So the coder has to make that adjustment mid-game, if you will, and make sure that they get this correct. This is not easy. Hopefully we'll all have a new respect for what coders do every day after looking at some of these issues. And then this is an example of a common thing I saw in the audit. This is one I predict will make a lot of people roll their eyes and sigh. Contrast UV240, the physician did not document if it is a high or low contrast. Believe it or not, that has an impact in the expected cost of care and length of stay for some patient populations, and it's something that's just kind of a nuisance. I see it coming up a lot, unfortunately, in these audits. The shock patient, shock unspecified, only a CC. If we know what's caused the shock, it shouldn't be unspecified, it should be shock other. Other is a major complicating or a severely ill patient, and shock unspecified is only a moderately ill patient. And that shouldn't be used for cases where the patient went into shock and we have no idea what happened to them. And that should be very, very rare. I see coders default to the unspecified a lot, but that's not the clinical truth. The clinical truth of it is that we usually do know what precipitated the shock, and we're losing all that severity whenever that happens. Then you have your shock anaphylactic. It could be due to food or an adverse effect of medications. Those are just moderately ill patients. Cardiogenic shock is a severely ill patient, as you can see. Gram-negative shock and severe sepsis is a severely ill patient. Hypovolemic shock is a severely ill patient. And hematological shock, that would also be the other would default to that, but that could also be things like transfusion reactions, those other sorts of complex shocks. Again, we know what caused it, but there's not a separate category for it, so it goes to other. And then you have your hemorrhagic, which can be post-procedural. If post-procedural, that will imply cause and effect. If you don't want to imply it, I recommend just going with acute blood loss anemia. And then you have your traumatic shock. Again, those are both severely ill patients, obviously. Let's see how we did on time. Hopefully, hurry up this time around. Oh, okay, we got about 7 minutes to open it up for questions. I see we have a lot of people on the phone, so I will turn